Topic for discussion today is an commonly encountered situation in the medicine slash nephrology OPD. Kidney cyst. Discussion is more focused towards which investigation to do. So before that, a short outline. Kidney cyst as the patient aged more than 40 years. A thin fluid filled cyst is very common in the kidney. It can occur anywhere and mostly it is benign. It is age related one. As the patient age progresses, usually it stays stable. Very less amount of it can be malignant. So related to that, what are the symptoms patient can have? As such, cyst, if it is size is big, it can cause pain. If the size is small, most of the time it might be an incidental finding. Incidental, that time only we are getting to know. So cyst is a simple one. But what are the differential diagnosis related to that? Sometimes it can be malignancy. That is the most important differential diagnosis. So one side, a simple cyst is a natural one. As the patient ages, it can be there. The another differential is malignancy. Most of the time in the ultrasound, as we see the incidental finding, what next? What next? The next best investigation related to renal cyst is the contrast enhanced CT. CECT have to be done, or contrast enhanced MRI. In these two, which one is preferred? CECT is preferred. The sensitivity is better. You can easily delineate. But in ultrasound, what are all the clues which says it might not be a simple cyst or it might need some kind of intervention? What are one is exophytic component. What is exophytic? Exophytic means the cyst is coming outside the kidney border. Then that is called as exophytic. Four important components you have to see. One is the margin. How is the margin? Whether it is regular or irregular. Whether septations are seen or not. Inside it, whether it is septations are seen or not. Third, what is the content? Whether is there any debris is there or is there any content is there. Mostly fat or fluid will be there. Content is there or not. Fourth is vascularity. Fifth one is calcification. So in the ultrasound, we won't be able to get all this, especially the vascularity we won't be able to see. Calcification bit difficult to find it out. So that is why to see all this we need the CECT. In the ultrasound, what are all the clues we will get? Size. If the size is more than 4 centimeter, there is a chance it might be a malignancy one or patient might require intervention. Mostly 90%. A larger cyst more than 4 centimeter can be benign 10% of the time. 90% of the time chances of malignancy is there. So one is the size. In the ultrasound, as you see more than 4 centimeter, you have to be alarmed that further investigations are very much mandatory. If the border is very much irregular, as you see the ultrasound image, you will able to see the borders. If it is irregular, be alarmed to get the next investigation very fast. When it is having a bigger exophytic component, when it is a big exophytic component, then it should be. Sometimes radiologist can say the vascularity is there. If they press the Doppler button while doing the ultrasound, the vascularity can, if it is there, there's a chances it is somewhat towards the malignancy. So as you see the ultrasound, you see if it's a clear component, well-rounded inside the kidney 1 centimeter, mostly it is benign. You can wait and decide on the next investigation. You can do it very gradually over a period of 6 months, 9 months. You can repeat and see. The size usually won't change. Even if it is changing and it is less than 4 centimeter, you can wait and watch. There is might not be an alarming one. When you find this side component, then you have to go for the contrast enhanced CT. CMRI is also as equal as CECT, but CECT is the best investigation because whether to do surgery, how much kidney to be cut and all, only can be best decided by CE, contrast enhanced CT. NCCT, very difficult to catch the vascularity. Enhancement we can't see. That is why we have to go for CECT. As I told, what are the things you will see? Content, boundaries, whether vascularity is there or not, whether calcification is there or not, inside any debris is there or not, septation is there or not, how is the border. These are the things you are going to see. In the contrast enhanced CT, you will able to see the vascularity also, that is enhancement also, whether the cyst is enhancing or not. Most of the time a benign cyst might not be enhancing. So CECT, as I discussed this, sometimes as a clinician you might find it difficult to see all the component in the section by putting it in the view box. So radiologists use a grading called Bosniak classification. Grade 1, 2, 2F, 3 and 4. 4 means there is a chances of malignancy, better to go for surgery. 3 and above is a follow-up. Class 1 means nothing to worry, it is a benign one. You can keep it in follow-up after 6 months, after 1 year you can do, nothing to worry. So that is why in the CECT or CEMRI you have to look at the Bosniak class. What class of the cyst is that? So regarding Bosniak class, there is a video already in the channel, you can look into it. They take into these components that I have described along with calcification and they will decide upon. So as the Bosniak class we will come to know whether to go for surgery or it is a benign lesion, just we have to observe. So 4 cm I told the cutoff. Many PGs will have doubts, sir, less than 4 cm should I go for CECT? Depends on the patient profile, whether loss of appetite, whether any signs of malignancy is there or not. Less than 1 cm you can clearly wait. 1 to 3 cm plan the investigation. More than 4 cm always get the investigation. Exophytic component and look for vascularity in the ultrasound and come for the CECT. Now comes the main purpose of this particular video. When the patient creatinine is high, then how to proceed with? Whether to go for CECT or what to do? If the patient eGFR is less than 30, that times it will be very difficult to decide whether to go for contrast or not. Even if the patient eGFR is less, which is the best investigation to know the diagnostic characteristic of that particular cyst, it's always the contrast enhancing CT or contrast enhanced MRI. But now, considering the patient eGFR, we can go for the plain MRI, but we might not get all the information which are required. So that is why, if the lesion mostly is of benign, go for a plain MRI and confirm it with the help of the MRI finding also along with the USG finding. Suppose if the border is irregular, exophytic component is there, more than 4 cm, or there is sign of vascularity, no other option, go for CECT. Because under high risk situation, you can use a low dose of contrast, giving the nephroprotective drugs like N-acetylcysteine, a good hydration. CECT have to be done. In this situation, CMRI can't be planned because contrast enhanced MRI is associated with more of nephrogenic systemic fibrosis, which is a deadly situation. Whereas contrast enhanced CT causes ATN, acute tubular necrosis, it can cause that also in some situation, not always. So even in a patient whose eGFR is less, patient cyst have to be characterized, which is having high risk of malignancy, go for CECT to clear it out once for all. Suppose if the signs, even in the ultrasound you are not getting, even though it is more than 4 cm, but it is well rounded, no vascularity, contents are very clear, go for MRI, just reconfirm it. No need to put the patient into CECT. So all depends on the clinical situation, age, and how suspicion of malignancy is there. That is why in the ultrasound, once you start seeing the image, eventually as your clinical accumulates, you will come to know which is what. A clear cyst you can easily, for example, this kind of clear cyst located inside the kidney, mostly you will come to know it is a benign one. As the exophytic component is there, you will come to know it might be a malignancy, not always malignancy. More than 4, what is the chance? 90%, but 10% it can be benign also. So first assure the patient, this is the outline. Best investigation CECT, eGFR is less. Look for signs of benign, which is malignant with ultrasound and decide on. Go for MRI if required, then come for CECT. MRI, plain MRI, not the contrast one. So this is all related to the kidney cyst. Most of the time in the OPD you might find it as incidental finding. Reassure the patient and follow the things that we have discussed. This is for today. Any doubts you can comment below. We will discuss in the video, and bye bye.